Interlobar fissures. The minor fissure separates the right upper lobe RUL from the right middle lobe RML, and is seen on both the frontal and lateral views as a fine horizontal line. The major oblique fissures are seen only on the lateral radiograph as oblique lines. However, if they are fluid-filled, the major fissures can be seen on the frontal view as concave curvilinear opacities in the lateral hemithorax. On the right, the major fissure separates the RUL and RML from the right lower lobe. On the left, the major fissure separates the left upper lobe LOL from the left lower lobe LLL. Accessory fissures. The azygous fissure is an accessory fissure present in less than 1% of patients, seen in the presence of an azygous lobe. An azygous lobe is an anatomic variant where a portion of the apical right upper lobe is encased in its own parietal and visceral pleura. The superior accessory fissure is seen in approximately 5% of patients and separates the superior and basal segments of the right lower lobe. The inferior accessory fissure is seen in approximately 12% of patients, more commonly in the right lung, and divides the medial basal segment from the other basal segments. The left minor fissure is present in approximately 8% of patients and separates the lingula from the left upper lobe. Overview of atelectasis. Atelectasis is loss of lung volume due to decreased aeration. Atelectasis is synonymous with collapse. Atelectasis may be caused by bronchial obstruction, mucus plugging, or external compression, e.g., by small lung volumes or pleural effusions. Direct signs of atelectasis are from lobar volume loss and include displacement of the fissures, plate-like or triangular opacity from the collapsed lung itself, vascular crowding. Indirect signs of atelectasis are due to the effect of volume loss on adjacent structures and include elevation of the diaphragm, rib crowding on the side with volume loss, mediastinal shift to the side with volume loss, overinflation of adjacent or contralateral lobes, hilar displacement. Air bronchograms are not seen in atelectasis when the cause of the atelectasis is central bronchial obstruction, but air bronchograms can be seen in atelectasis caused by external compression. Mechanisms of atelectasis. Obstructive atelectasis occurs when alveolar gas is absorbed by blood circulating through alveolar capillaries but is not replaced by inspired air due to bronchial obstruction. Obstructive atelectasis can cause lobar atelectasis, which is complete collapse of a lobe, discussed on the following pages. Obstructive atelectasis occurs more quickly when the patient is breathing supplemental oxygen since oxygen is absorbed from the alveoli more rapidly than nitrogen. In children, airway obstruction is most often due to an aspirated foreign object. In contrast to adults, the affected side becomes hyperexpanded in children due to a ball valve effect. Subsegmental atelectasis is a subtype of obstructive atelectasis commonly seen after surgery or general illness, due to mucus obstruction of the small airways. Relaxation passive atelectasis is caused by relaxation of lung adjacent to an intrathoracic lesion causing mass effect, such as a pleural effusion, pneumothorax, or pulmonary mass. Adhesive atelectasis is due to surfactant deficiency. Adhesive atelectasis is seen most commonly in neonatal respiratory distress syndrome, but can also be seen in acute respiratory distress syndrome (ARDS). Cicatricial atelectasis is volume loss from architectural distortion of lung parenchyma by fibrosis. Lobar atelectasis. Lobar atelectasis is usually caused by central bronchial obstruction, obstructive atelectasis, which may be secondary to mucus plugging or an obstructing neoplasm. If the lobar atelectasis occurs acutely, mucus plugging is the most likely cause. Mucus plugging is most common in the lower lobes, least common in the left upper lobe. If lobar atelectasis is seen in an outpatient, an obstructing central tumor must be ruled out. Lobar atelectasis, or collapse of an entire lobe, has characteristic appearances depending on which of the 5 lobes is collapsed, as discussed on the following pages. Patterns of lobar atelectasis. Frontal schematic. Lateral schematic. Right lung, left lung, RLL, RLL, RML, RML, RUL, RUL, LLL, LLL, LOL. Illustration showing direction of collapse for each of the 5 lobes. Left upper lobe atelectasis. Left upper lobe collapse and Luftsichel sign. Frontal radiograph left image shows veil-like opacity with obscured left cardiac margin, a characteristic finding of left upper lobe collapse on frontal view. Note the crescent of air lateral to the aortic arch representing the Luftsichel sign, yellow arrow. The lateral view right image shows the anterior displacement of the left major fissure and collapsed left upper lobe, red arrows. Key imaging findings include the veil-like opacity on frontal radiograph, anterior displacement of major fissure and anterior collapsed lung on lateral radiograph. The Luftsichel ERC in German sign is a crescent of air seen on the frontal radiograph, which represents the interface between the aorta and the hyperexpanded superior segment of the left lower lobe. However, this sign is not always present. It is important to recognize left upper lobe collapse and not mistake the left lung opacity for pneumonia or pleural effusion, since a mass obstructing the airway may be the cause of the lobar atelectasis. Right upper lobe atelectasis. Right upper lobe collapse. Frontal radiograph left image shows a right upper lobe opacity with superior displacement of the minor fissure, blue arrow, and a convex mass golden S sign, yellow arrow. Lateral radiograph right image shows the wedge-shaped collapsed RUL projecting superiorly, red arrows. The reverse S sign of golden is seen in right upper lobe collapse caused by an obstructing mass. The central convex margins of the mass form a reverse S. Although the sign describes a reverse S, it is also commonly known as the golden S sign. Similar to left upper lobe collapse, a right upper lobe collapse should raise concern for an underlying malignancy in adults or mucus plugging, particularly common in children. The juxtaphrenic peak sign is a paradiaphragmatic triangular opacity caused by diaphragmatic traction from an inferior accessory fissure or an inferior pulmonary ligament, seen in upper lobe volume loss from any cause. Left lower lobe atelectasis. Left lower lobe collapse. Frontal radiographs demonstrate a triangular retrocardiac opacity representing the collapsed left lower lobe, yellow arrows. Lateral radiograph shows posterior hazy opacity, red arrows. Triangular retrocardiac opacity is the main imaging feature of left lower lobe collapse. The flat waist sign describes the flattening of the left heart border due to posterior shift of hilar structures and resultant cardiac rotation. Right lower lobe atelectasis. Right lower lobe collapse. Frontal radiograph shows a triangular opacity at the right lower zone with apex pointing towards the right hilum and obscuration of the medial right hemidiaphragm, blue arrow. Note there is preservation of the right heart border. Lateral radiograph shows a hazy posterior opacity of the collapsed right lower lobe, red arrows. Right lower lobe atelectasis is the mirror image of left lower lobe atelectasis. Lower lobe collapse is not well seen on lateral views since the lobes mostly collapse medially. The collapsed lower lobe appears as a triangular retrocardiac opacity. Right middle lobe atelectasis. Right middle lobe atelectasis. Frontal chest radiograph shows an indistinct opacity in the right lung with focal silhouetting of the right heart border, blue arrows. There is elevation of the right hemidiaphragm due to volume loss. The lateral radiograph shows a triangular opacity, red arrow, projecting over the mid-heart representing the collapsed right middle lobe. The findings of right middle lobe atelectasis can be subtle on the frontal radiograph. Silhouetting of the right heart border by the collapsed medial segment of the middle lobe may be the only clue. The lateral radiograph shows a triangular opacity anteriorly. Collapse of both right middle and lower lobes occurs from obstruction of the bronchus intermedius, and it causes obscuration of both the right heart border and right hemidiaphragm, with a linear superior margin directed towards the hilum. Round atelectasis. Round atelectasis is focal atelectasis with a round morphology that is always associated with an adjacent pleural abnormality, e.g., pleural effusion, pleural thickening or plaque. Round atelectasis is most common in the posterior lower lobes. All 5 of the following findings must be present to diagnose round atelectasis. 1. Adjacent pleura must be abnormal. 2. Opacity must be peripheral and in contact with the pleura. 3. Opacity must be round or elliptical. 4. Volume loss must be present in the affected lobe. 5. Pulmonary vessels and bronchi leading into the opacity must be curved. This is the comet tail sign. Round atelectasis. Non-contrast CT shows a rounded opacity in the medial right lower lobe, red arrows. This example meets all 5 criteria for round atelectasis including adjacent pleural abnormality, effusion, opacity in contact with the pleura, round shape, volume loss in the affected lobe, and the comet tail sign, yellow arrows, representing curved vessels and bronchi leading to the focus of round atelectasis. Patterns of lung disease. Essential anatomy. Secondary pulmonary lobule, SPL. Acinus, not visible on CT. Approximately 12 per secondary lobule, acinar artery and respiratory bronchiole, centrilobular bronchus and artery. 1 cm, 2 cm, 3 cm. Approximate scale. Pulmonary veins and lymphatics, not pictured, run in the interlobular septa. The secondary pulmonary lobule, SPL, is the elemental unit of lung function. Each SPL contains a central artery, the aptly named centrilobular artery, and a central bronchus, each branching many times to ultimately produce acinar arteries and respiratory bronchioles. On CT, the centrilobular artery is often visible as a faint dot. The centrilobular bronchus is not normally visible. The acinus is the basic unit of gas exchange, containing several generations of branching respiratory bronchioles, alveolar ducts, and alveoli. There are generally 12 or fewer acini per secondary lobule. Pulmonary veins and lymphatics collect in the periphery of each SPL. Connective tissue, called interlobular septa, encases each SPL. Thickening of the interlobular septa can be seen on CT and suggests pathologic enlargement of either the venous or lymphatic spaces, as discussed on subsequent pages. Each SPL is between 1 and 2.5 cm in diameter. Abnormalities of the secondary pulmonary lobule. Consolidation and ground glass. Consolidation and ground glass opacification are two very commonly seen patterns of lung disease caused by abnormal alveoli. The alveolar abnormality may represent either filling of the alveoli with fluid or incomplete alveolar aeration. Consolidation can be described on either a chest radiograph or CT, while ground glass is generally reserved for court. Although consolidation often implies pneumonia, both consolidation and ground glass are nonspecific findings with a broad differential depending on chronicity, acute versus chronic, and distribution, focal versus patchy or diffuse. Consolidation. Consolidation. Contrast-enhanced CT shows bilateral consolidative opacities, more densely consolidated on the left. There are bilateral air bronchograms. Although these imaging findings are nonspecific, this was a case of multifocal consolidative adenocarcinoma. Consolidation is histologically due to complete filling of affected alveoli, commonly remembered as blood, pus, water, or cells. Pulmonary vessels are not visible through the consolidation on an unenhanced court. Air bronchograms are often present if the airway is patent. An air bronchogram represents a lucent air-filled bronchus, or bronchiole, seen within a consolidation. Consolidation causes silhouetting of adjacent structures on conventional radiography. Acute consolidation is most commonly due to pneumonia, but the differential includes pneumonia, by far the most common cause of acute consolidation. Aspiration. Consolidation may appear heterogeneous from mucus plugging. Pulmonary hemorrhage, primary pulmonary hemorrhage or aspiration of hemorrhage. Adult respiratory distress syndrome, ARDS, which is noncardiogenic pulmonary edema seen in critically ill patients and thought to be due to increased capillary permeability. Pulmonary edema may cause consolidation if severe. The differential diagnosis of chronic consolidation includes adenocarcinoma, previously bronchial-alveolar carcinoma, lymphoma, organizing pneumonia, which is a nonspecific response to injury characterized by granulation polyps which fill the distal airways, producing peripheral rounded and nodular consolidation. Chronic eosinophilic pneumonia, an inflammatory process characterized by eosinophils causing alveolar filling in an upper lobe distribution. Ground glass opacification, GGO. Ground glass opacification. Non-contrast CT shows diffuse ground glass opacification, GGO. The pulmonary architecture, including vasculature and bronchi, can be still seen, which is characteristic for GGO. Although these imaging findings are nonspecific, this was a case of acute respiratory distress syndrome, ARDS. Ground glass opacification is histologically due to either partial filling of the alveoli by blood, pus, water, or cells, alveolar wall thickening, or reduced aeration of alveoli, atelectasis. Ground glass is usually a term reserved for court. CT shows a hazy, gauze-like opacity, through which pulmonary vessels are still visible. Acute ground glass opacification has a similar differential to acute consolidation, since many of the entities that initially cause partial airspace filling can progress to completely fill the airspaces later in the disease. The differential of acute ground glass includes pulmonary edema, which is usually central or dependent. Pneumonia. Unlike consolidation, ground glass is more commonly seen in atypical pneumonias such as viral or pneumocystis jirovecii pneumonia. Pulmonary hemorrhage, seen as pure ground glass in acute phase, but subacute phase shows peripheral sparing and crazy paving. Adult respiratory distress syndrome, ARDS. Chronic ground glass opacification has a similar but broader differential diagnosis compared to chronic consolidation. In addition to all of the entities which may cause chronic consolidation, the differential diagnosis of chronic ground glass also includes lung adenocarcinoma, which can be focal or multifocal, organizing pneumonia, typically presenting as rounded, peripheral opacities. Chronic eosinophilic pneumonia, usually with an upper lobe predominance. Interstitial lung disease, including desquamative interstitial pneumonia, DIP, nonspecific interstitial pneumonia, NSIP, and hypersensitivity pneumonitis, HP. Hypersensitivity pneumonitis, HP, is a type 3 hypersensitivity reaction to inhaled organic antigens. In the subacute phase there is ground glass, centrilobular nodules, and mosaic attenuation. Peripheral ground glass or consolidation. Coronal schematic demonstrates peripheral ground glass. Axial CT shows peripheral and subpleural ground glass attenuation. This was a case of organizing pneumonia. The differential diagnosis for peripheral consolidation or ground glass includes organizing pneumonia, chronic eosinophilic pneumonia, typically with an upper lobe predominance, pulmonary infarction, interlobular septal thickening, smooth. Schematic demonstrates smooth interlobular septal thickening. Smooth interlobular septal thickening. CT demonstrates smooth thickening of the interlobular septa arrows in pulmonary edema. Courtesy retu. Conditions that dilate the pulmonary veins cause smooth interlobular septal thickening. By far the most common cause of smooth interlobular septal thickening is pulmonary edema. However, the differential diagnosis for smooth interlobular septal thickening is pulmonary edema, lymphangitis carcinomatosis, interlobular septal thickening, nodular, irregular, or asymmetric. Schematic demonstrates irregular and nodular interlobular septal thickening. Axial CT shows a diffuse nodular septal thickening, yellow arrows. This was a case of lymphangitic carcinomatosis. Nodular, irregular, or asymmetric septal thickening tends to be caused by processes that infiltrate the peripheral lymphatics, most commonly by lymphangitic carcinomatosis and sarcoidosis. Lymphangitic carcinomatosis is tumor spread through the lymphatics. Sarcoidosis rarely causes septal thickening. Crazy paving. Schematic demonstrates interlobular septal thickening and ground glass opacification. Axial CT shows interlobular septal thickening in regions of ground glass opacification, representing crazy paving. This was a case of alveolar proteinosis, the entity in which crazy paving was first described. Crazy paving describes interlobular septal thickening with superimposed ground glass opacification, which is thought to resemble the appearance of a stone path. Although nonspecific, this pattern was first described for alveolar proteinosis, where the ground glass opacification is caused by filling of alveoli by proteinaceous material and the interlobular septal thickening is caused by lymphatics taking up the same material. The differential diagnosis for crazy paving includes pulmonary edema, by far the most common cause, pulmonary hemorrhage, acute respiratory distress syndrome, pulmonary alveolar proteinosis (PAP), and idiopathic disease characterized by alveolar filling by a proteinaceous substance. PAP is almost always seen with a crazy paving pattern. Pneumocystis jirovecii pneumonia, adenocarcinoma, uncommon cause, lipoid pneumonia, an inflammatory pneumonia caused by reaction to aspirated lipids, uncommon cause. Approach to multiple micronodules, centrilobular form, trail, O, E, F, E, C, I, E, N, N, dash, T, B, Re, U, low, D, bular paralymphatic random, viral pneumonia, hypersensitivity pneumonitis aspiration, pulmonary capillary hemangiomatosis metastatic calcification. Occasionally, pulmonary edema, infectious bronchiolitis, mycobacterial infections, viral infections, bacterial pneumonia aspiration. Rarely, lymphangitic carcinomatosis and vascular abnormalities, endovascular metastasis and pulmonary arterial aneurysms. Sarcoidosis, pneumoconiosis, lymphangitic carcinomatosis, hematogenous metastasis, disseminated mycobacteria, disseminated fungal infections. Patterns. KBPG14. Random. Metastasis. Infection, miliary Tb, fungal. Centrilobular. Aspiration. In number 1F, amatory, HP, RB, infection, viral, mycobacterial. Centrilobular nodules. Schematic demonstrates a centrilobular nodule, located at the center of the pulmonary lobule. Axial CT demonstrates diffuse faint centrilobular opacities, arrows, none of which extend to the pleural surface, which is typical of a centrilobular distribution. This was a case of pulmonary capillary hemangiomatosis. Centrilobular nodules represent opacification of and around the centrilobular bronchiole, or less commonly the centrilobular artery, at the center of each secondary pulmonary lobule. On CT, Multiple small nodules are seen in the centers of secondary pulmonary lobules. Centrilobular nodules never extend to the pleural surface. The nodules may be solid or of ground glass attenuation, and range in size from tiny up to a centimeter. Centrilobular nodules may be caused by infectious or inflammatory conditions. Infectious causes of centrilobular nodules include viral pneumonias. The most common inflammatory cause of centrilobular nodules is hypersensitivity pneumonitis, HP, and exposure-related lung disease. HP is a type 3 hypersensitivity reaction to an inhaled organic antigen. The acute or subacute presentation of HP is primarily characterized by centrilobular nodules. Pulmonary capillary hemangiomatosis is a vascular pathology characterized by abnormal capillary proliferation leading to pulmonary hypertension. Viral pneumonias. Aspiration is dependent. Metastatic calcification most commonly occurs in the lung apices, typically in patients with renal failure. Paralymphatic nodules. Paralymphatic nodules. Schematic of the secondary pulmonary lobule, left image demonstrates gray nodules located along the bronchovascular bundle and white nodules located along the interlobular septa. Axial CT, right image, demonstrates multiple subpleural nodules and nodules along the bronchovascular bundles, arrows. This was a case of sarcoidosis. Paralymphatic nodules follow the anatomic locations of pulmonary lymphatics, which can be seen in 3 locations in the lung. 1. Subpleural. 2. Parabronchovascular. 3. Septal, within the interlobular septa separating the secondary pulmonary lobules. Sarcoidosis is the most common cause of paralymphatic nodules, typically with an upperlobe distribution. The nodules may become confluent, creating the galaxy sign in which many tiny nodules surround a central lesion. Pulmonary sarcoidosis with galaxy sign. Axial and coronal CT images demonstrate extensive upper lobe predominant confluent paralymphatic nodules. The galaxy sign is most apparent on the axial image, where the confluent nodules appear like the confluence of stars forming a galaxy. The differential of paralymphatic nodules includes sarcoidosis, pneumoconiosis, silicosis, and coal workers' pneumoconiosis, or reactions to inorganic dust inhalation. The imaging may look identical to sarcoidosis with paralymphatic nodules, but there is usually a history of exposure, e.g., a sandblaster who develops silicosis. Lymphangitic carcinomatosis. Random nodules. Random nodules. Schematic of the secondary pulmonary lobule, top left image, demonstrates nodules distributed randomly throughout the SPL. Schematic of the lungs, bottom left image, demonstrates nodules scattered randomly. Some of the nodules are in close contact with the pleural surface. Axial CT, top right image, demonstrates multiple random nodules. Some of the nodules abut the pleural surface. This was a case of metastatic colon cancer. Randomly distributed nodules usually occur via hematogenous spread. The differential of random nodules includes hematogenous metastasis, disseminated mycobacteria, disseminated fungal infection. A miliary pattern is innumerable tiny random nodules the size of millet seeds. Miliary nodules. Axial CT shows innumerable tiny nodules distributed randomly throughout both lungs in a miliary pattern. This was a case of miliary tuberculosis. Case courtesy Ritu R. Gill, MD, MPH, Brigham and Women's Hospital. Tree and bud nodules. Schematic shows several nodules centered on an opacified small airway. Tree and bud nodularity. Axial CT shows numerous small nodules, arrows, budding off of linear branching structures in the right middle lobe. This case was secondary to atypical mycobacteria. Tree and bud nodules are multiple small nodules connected to linear branching structures, which resemble a budding tree branch in springtime. The linear branching structures represent mucus-impacted bronchioles, which are normally invisible on court, and the nodules represent impacted terminal bronchioles. Tree and bud nodules are due to mucus, pus, or fluid impacting bronchioles and terminal bronchioles. Tree and bud nodules are almost always associated with small airways infection or inflammation, such as endobronchial spread of tuberculosis. The differential of tree and bud nodules includes Mycobacterium tuberculosis and atypical mycobacteria. Viral pneumonia. Aspiration pneumonia. Rarely. Lymphangitic carcinomatosis and vascular abnormalities, endovascular metastasis and pulmonary arterial aneurysms. Cavitary and cystic lung disease. Solitary cavitary nodule, mass. Coronal schematic demonstrates a single cavitary lesion. Axial CT shows a single spiculated cavitary lesion in the left upper lobe, arrow. This was a case of squamous cell carcinoma. A cavitary lesion represents development of air within a pre-existing lesion, nodule, mass, or consolidation. It typically has a thick, irregular wall, often with a solid mural component. Although the findings of benign and malignant cavitary nodules overlap, a maximum wall thickness of is less than or equal to 4 mm is usually benign and a wall thickness greater than 15 mm is usually malignant. Spiculated margins also suggest malignancy. A solitary cavitary lesion is most likely cancer or infection. Primary bronchogenic carcinoma. While both squamous cell and adenocarcinoma can cavitate, squamous cell cavitates more frequently. Small cell carcinoma is never known to cavitate. Tuberculosis classically produces an upper lobe cavitary consolidation. Fungal pneumonia. Cavitary bacterial pneumonia. Multiple cavitary nodules. Coronal schematic shows numerous cavitary lesions bilaterally. Axial CT shows numerous cavitary and non-cavitary lesions bilaterally, in a random distribution. This was a case of polysubstance abuse and septic emboli. The differential diagnosis for multiple cavitary lesions includes septic emboli, typically peripheral, vasculitis, including granulomatosis with polyangiitis, GPA, metastasis, classically squamous cell carcinoma, but any metastatic lesion can cavitate. Cystic lung diseases. Coronal schematic shows numerous thin-walled cystic lesions bilaterally. Axial CT shows bilateral thin-walled cysts that are of varying sizes but are predominantly regular in shape. There is a small left pleural effusion. This was a case of lymphangioliomyomatosis. A cyst is an air-containing space with a thin wall. The differential diagnosis for multiple lung cysts includes lymphangioliomyomatosis, LAM, a diffuse cystic lung disease due to smooth muscle proliferation of the distal airways. LAM causes uniformly distributed, thin-walled cysts in a diffuse distribution. It may be associated with chylous effusion, as demonstrated in the above right case. Pulmonary Langerhans cell histiocytosis, which features irregular cysts and nodules predominantly in the upper lungs. Lymphoid interstitial pneumonia, LIP, a rare disease usually associated with Sjogren syndrome and characterized by lymphocytic infiltrate and multiple cysts. Amyloid, which appears similar to LIP. Birt-Hogg-Dubé syndrome, which is an autosomal dominant genetic disorder characterized by renal tumors, most commonly chromophobe renal carcinoma and renal oncocytoma, and renal and pulmonary cysts. Spontaneous pneumothoraxes can occur as a sequela of pulmonary cysts. Pneumocystis jirovecii pneumonia, which features cysts in late-stage disease. Of note, it is important to distinguish cysts from emphysema. The latter typically does not have walls and may have central vessels, whereas cysts classically do not have anything inside. The differential for a single cyst includes bulla. A bulla is an air-filled emphysematous space measuring greater than 1 cm. A giant bulla occupies at least 30% of the volume of the thorax. Bleb. A bleb is an air-filled cystic structure contiguous with the pleura measuring less than 1 cm. Rupture of a bleb is the most common cause of spontaneous pneumothorax. Pneumatocele, which is an air-filled space caused by prior lung trauma or infection. Fibrotic changes. Lower lobe fibrotic changes. Coronal schematic shows basal predominant fibrotic changes. Coronal CT shows bibasilar fibrosis and honeycombing arrows with relative sparing of the upper lobes. This was a case of idiopathic pulmonary fibrosis. The differential diagnosis of basal predominant fibrotic change includes usual interstitial pneumonia, Uip pattern. Idiopathic pulmonary fibrosis, IPF, is a clinical syndrome of progressive pulmonary fibrosis of unknown etiology and is the most common cause of basilar fibrosis. It almost always features basilar honeycombing. Other causes of Uip pattern, including rheumatoid arthritis and asbestosis. Nonspecific interstitial pneumonia, NSIP, is a lung response to injury commonly associated with collagen vascular disease and drug reaction. NSIP typically produces parabronchial reticulation and traction bronchiectasis. Ground glass may be present. Upper lobe fibrotic changes. Coronal schematic shows fibrotic changes in the upper lobes. Coronal CT shows upper lobe predominant subpleural fibrosis and traction bronchiectasis. A pathologic diagnosis was not established in this case. Although IPF is the most common cause of pulmonary fibrosis, fibrosis primarily affecting the upper lobes is typically caused by an alternative diagnosis, such as end-stage sarcoidosis. Sarcoidosis is a disease that primarily affects the upper lobes. The late stage of sarcoidosis leads to upper lobe predominant fibrosis. Chronic hypersensitivity pneumonitis. End-stage silicosis. The late stage of silicosis may lead to fibrosis with an upper lobe predominance. Pulmonary infection. Clinical classification of pneumonia. Community-acquired pneumonia, CAP. S. pneumoniae is the most common cause of community-acquired pneumonia, CAP. Atypical pneumonia, including mycoplasma, viral, and chlamydia, typically infects young and otherwise healthy patients. Mycoplasma has a varied appearance and can produce consolidation, areas of ground glass attenuation, centrilobular nodules, and tree and bud nodules. Legionella most commonly occurs in elderly smokers. Infections tend to be severe. Infection by Klebsiella and other gram-negatives occurs in alcoholics and aspirators. Klebsiella classically leads to voluminous inflammatory exudates causing the bulging fissure sign. Hospital-acquired pneumonia, HAP. Hospital-acquired pneumonia, HAP, occurs in hospitalized patients and is due to aspiration of colonized secretions. HAP is caused by a wide variety of organisms, but the most important pathogens include MRSA and resistant gram-negatives including Pseudomonas. Healthcare-associated pneumonia, HCAP. Healthcare-associated pneumonia is defined as pneumonia in a nursing home resident or in a patient with a greater than 2-day hospitalization over the past 90 days. Pathogens are similar to HAP. Ventilator-associated pneumonia, VAP. Ventilator-associated pneumonia is caused by infectious agents not present at the time mechanical ventilation was started. Most infections are polymicrobial and primarily involve gram-negative rods such as Pseudomonas and Acinetobacter. Pneumonia in the immunocompromised patient. Any of the above pathogens, plus opportunistic infections including pneumocystis, fungi such as Aspergillus, nocardia, CMV, etc., can be seen in immunocompromised patients. Different types of immunocompromise can lead to different infections. In particular, neutropenia predisposes to fungal pneumonia. Radiographic patterns of infection. Lobar pneumonia. Lobar pneumonia is consolidation of a single lobe. It is usually bacterial in origin and is the most common presentation of community-acquired pneumonia. The larger bronchi remain patent, causing air bronchograms. Bronchopneumonia. Bronchopneumonia is patchy parabronchial consolidation with airspace opacities, usually involving several lobes, and may be caused by both bacterial and viral pneumonias as well as aspiration. Interstitial pneumonia. Interstitial pneumonia is a misnomer, a finding on CXR that usually corresponds to ground glass on court. Generally it can be caused by atypical, e.g., mycoplasma, chlamydia, viral, or pneumocystis pneumonia. Round pneumonia. Round pneumonia is an infectious mass-like opacity seen in children, most commonly due to S. pneumoniae. Infection remains confined due to incomplete formation of pores of cone. Complications of pneumonia. Pulmonary abscess. Pulmonary abscess is necrosis of the lung parenchyma typically due to Staphylococcus aureus, Pseudomonas, or anaerobic bacteria. An air fluid level is often present. An abscess is usually spherical, with equal dimensions on frontal and lateral views. Empyema. Empyema is infection within the pleural space. There are 3 stages in the development of an empyema. 1. Free-flowing exudative effusion, can be treated with needle aspiration or simple drain. 2. Development of fibrous strands, requires large bore chest tube and fibrinolytic therapy. 3. Fluid becomes solid and jelly-like, usually requires surgery. Although pneumonia is often associated with a parapneumonic effusion, most pleural effusions associated with pneumonia are not empyema, but are instead a sterile effusion caused by increased capillary permeability. An empyema conforms to the shape of the pleural space, causing a longer air fluid level on the lateral radiograph. This is in contrast to an abscess, discussed above, which typically is spherical and has the same dimensions on the frontal and lateral radiographs. The split pleura sign describes enhancing parietal and visceral pleura of an empyema seen on contrast-enhanced study. Split pleura sign. Contrast-enhanced CT shows enhancement of the thickened visceral and parietal pleural layers, arrows, which encase a pleural fluid collection. The split pleura sign is seen in the majority of exudative effusions, although it is not specific. Similar findings can be seen in malignant effusion, mesothelioma, fibrothorax, and after talc pleurodesis. Case courtesy Ritu R. Gill, MD, MPH, Brigham and Women's Hospital. Empyema necessitans. Empyema necessitans is extension of an empyema to the chest wall, most commonly secondary to tuberculosis. Other causative organisms include actinomyces. Pneumatocele. A pneumatocele is a thin-walled, gas-filled cyst that may be post-traumatic or develop as a sequela of pneumonia, typically from Staphylococcus aureus or pneumocystis. Bronchopleural fistula (BPF). Bronchopleural fistula (BPF) is an abnormal communication between the airway and the pleural space. It is caused by rupture of the visceral pleura. By far the most common cause of BPF is surgery. However, other etiologies include lung abscess, empyema, and trauma. On imaging, new or increasing gas is present in a pleural effusion. A connection between the bronchial tree and the pleura is not always apparent, but is helpful when seen. The treatment of BPF is controversial and highly individualized. Tuberculosis (TB). Tuberculosis (TB), caused by Mycobacterium tuberculosis, remains an important disease despite remarkable progress in public health and antituberculous therapy over the past century. Tuberculosis remains a significant problem in developing countries. In the United States, TB is seen primarily in immigrant, institutionalized, and immunocompromised individuals. Initial exposure to TB can lead to two clinical outcomes. 1. Contained disease 90% results in calcified granulomas and/or calcified hilar lymph nodes. In a patient with normal immunity, the tuberculous bacilli are sequestered with a caseating granulomatous response. 2. Primary tuberculosis results when the host cannot contain the organism. Primary tuberculosis is seen more commonly in children and immunocompromised patients. Reactivation post-primary TB is reactivation of a previously latent infection. Primary tuberculosis. Primary TB. Chest radiograph left image shows a vague right upper lung opacity arrow. CT shows a patchy opacification arrow in the lower portion of the right upper lobe with adjacent tree and bud nodularity. The patient's sputum grew Mycobacterium tuberculosis. Case courtesy Ritu R. Gill, MD, MPH, Brigham and Women's Hospital. Primary TB represents infection from the first exposure to TB. Primary TB may involve the pulmonary parenchyma, the airways, and the pleura. Primary TB often causes adenopathy. As many as 15% of patients infected with primary TB have no radiographic changes and the imaging appearance of primary TB is nonspecific. The typical imaging manifestation of primary TB is lobar consolidation plus pleural effusion and lymphadenopathy, although not all of these need to be present. Primary TB may occur in any lobe. Both primary and reactivation TB can also present as isolated pleural disease or miliary disease. See next section on miliary TB. Classic imaging findings are not always seen, but include gone focus, initial focus of parenchymal infection, usually located in the upper part of the lower lobe or the lower part of the upper lobe. Rank complex, gone focus and lymphadenopathy. Cavitation is rare in primary TB, in contrast to reactivation TB. Adenopathy is common in primary TB, typically featuring central low attenuation and tuberculous adenopathy. Contrast-enhanced neck CT shows marked right-sided adenopathy arrows with peripheral enhancement and central necrosis. Case courtesy Ritu R. Gill, MD, MPH, Brigham and Women's Hospital. Reactivation post-primary tuberculosis. Reactivation TB, also called post-primary TB, usually occurs in adolescents and adults and is caused by reactivation of a dormant infection acquired earlier in life. Clinical manifestations of reactivation TB include chronic cough, low-grade fever, hemoptysis, and night sweats. Reactivation TB most commonly occurs in the upper lobe apical and posterior segments and superior segments of the lower lobes. Reactivation TB. Frontal chest radiograph left image shows a cavitary lesion in the left upper lobe arrow confirmed by CT arrow. There was no significant mediastinal adenopathy. The differential diagnosis of this appearance would include cavitary primary lung cancer, which would be expected to feature a thicker wall. Case courtesy Michael Hanley, MD, University. In an immunocompetent patient, the imaging hallmarks of reactivation TB are upper lobe predominant consolidation with cavitation. Tree and bud nodules are common and suggest active endobronchial spread. Low attenuation adenopathy is a common additional finding, seen more often in immunocompromised patients. A tuberculoma is a well-defined rounded opacity consisting of an encapsulating fibrous wall with central caseation, usually in the upper lobes. Healed tuberculosis. Healed TB. Radiograph shows scarring, volume loss, and superior hilar retraction arrows. CT shows apical scarring. Case courtesy Ritu R. Gill, MD, MPH, Brigham and Women's Hospital. Healed TB is evident on radiography as apical scarring, usually with upper lobe volume loss and superior hilar retraction. Calcified granulomas may be present as well, which indicate containment of the initial infection by a delayed hypersensitivity response. Miliary tuberculosis. Miliary Tb. Radiograph and CT show innumerable tiny nodules in a random pattern, reflecting hematogenous seeding of Tb. Case courtesy Ritu R. Gill, MD, MPH, Brigham and Women's Hospital. Miliary Tb is a diffuse random distribution of tiny nodules seen in hematogenously disseminated Tb. Miliary Tb can occur in primary or reactivation Tb. Atypical mycobacteria. Atypical mycobacteria infection. Mycobacterium avium intracellular infection. Coronal left image and axial CT show right upper lobe and lingular tree and bud opacities and bronchiectasis, with more focal consolidation in the lingula arrow. There are three types of atypical mycobacterial infection. 1. Classic, or nodular cavitary form that simulates Tb, typically seen in patients with chronic lung disease. 2. Non-classic or bronchiectatic form, more common. 3. Disseminated form, typically lymphadenopathy in immunocompromised patients, usually AIDS. The presentation of bronchiectatic atypical mycobacteria is an elderly woman with cough, low-grade fever, and weight loss, called Lady Windermere syndrome. Mycobacterium avium intracellular and M. kase are the two most common organisms. Radiographic findings are bronchiectasis and tree and bud nodules, most common in the right middle lobe and lingula. Hot tub, lung. Hot tub, lung is a hypersensitivity pneumonitis in response to atypical mycobacteria, which are often found in hot tubs. There is no active infection and the typical patient is otherwise healthy. Imaging is similar to other causes of hypersensitivity pneumonitis, featuring centrilobular nodules. Endemic fungi. Endemic fungi can cause pneumonia in normal individuals, with each subtype having a specific geographic distribution. Histoplasma capsulatum. Histoplasma capsulatum is localized to the Ohio and Mississippi River valleys, in soil contaminated with bat or bird guano. Acute infection usually produces nodules and lymphadenopathy. Chronic sequela of infection is a calcified granuloma. A less common radiologic manifestation is a pulmonary nodule, histoplasmoma, which can mimic a neoplasm. Fibrosing mediastinitis is a rare complication of histoplasma infection of mediastinal lymph nodes leading to pulmonary venous obstruction, bronchial stenosis, and pulmonary artery stenosis. Affected lymph nodes tend to calcify. Coccidioides amitis and blastomyces dermatitis. Coccidioides amitis is found in the southwestern United States and has a variety of radiologic appearances, including multifocal consolidation, multiple pulmonary nodules, and miliary nodules. Blastomyces dermatitis is found in the central and southeastern United States. Infection is usually asymptomatic, but may present as flu-like illness that can progress to multifocal consolidation, ARDS, or miliary disease. Viral pneumonia. In general, viral pneumonias have a large overlap with bacterial pneumonias in imaging appearance. Classic imaging findings on CT include centrilobular or tree and bud nodules, patchy ground glass opacities, and bronchopneumonia, parabronchial consolidations. Severe acute respiratory syndrome coronavirus 2, SARS-CoV-2. Severe acute respiratory syndrome coronavirus 2 SARS-CoV-2, i.e., COVID-19, is a respiratory viral disease that became a pandemic in early 2020. Imaging findings are nonspecific, however bilateral, dependent, lower lobe predominant ground glass opacities or consolidations are classic features. Pleural effusions, centrilobular nodules, and tree and bud nodules are typically not associated. COVID-19 infection. Chest radiograph, left image, shows bilateral peripheral opacities, arrows. Chest CT, right, in a different patient shows peripheral ground glass and consolidations in both lungs, arrows.